Bonjour. I will just continue in English. It's going to be faster. That's the only reason. I will have a short lecture on the anatomy of the anterolateral structures. I'm really happy to be on a meeting which is dedicated to the ACL only, because in my humble opinion, most of the big societies really underappreciate nowadays the importance of this little piece of tissue inside the human knee. And I think the massive audience proves this point. So very interesting topic, already in 2010, of course, where the story starts in our case, where we were confronted with a lot of ACL patients, and they had some interesting and peculiar observations. One of the publications at that time is this one. This is a survival analysis after ACL reconstruction. You can see the failure rate. Massive failure rate. We didn't understand why so many of these patients failed early after surgery. Moreover, we had a phenomenon which is called the pivot shift, as you know, which we witnessed in a lot of these ACL injured patients. But some of them, they didn't show a positive pivot shift, although the MRI showed the same ACL injury. On the other hand, some of our patients we operated on, single and double bundle at that time, they kept on showing an increased tibial rotational excursion when we tested them in our gait lab, as you can see there. So we didn't understand what was going on with all these things, and we even didn't understand what the second fracture was. So that made us think that we were missing something at that time. And so thinking about this phenomenon, this rotational aspect in the human knee, is actually not very logical, that if you have these two rotating planes, that the ACL, which sits in the middle of this knee, can really prevent internal rotation of the tibia relative to the femur. A structure which is at the lateral sides is just biomechanically far more effective, just by the principle of the wheel and axle biomechanical principle. The only thing was that when we thought about this and sat down and looked into our results and literature, we didn't really find anything what was known on a potential ligament sitting at this lateral aspect of the knee which could control rotation. And so we went to our beautiful library in Leuven, a very old building where we could find some older publications, and this was the first of the real Dr. Paul Seguin, of course, the French surgeon, which has published a thesis in 1879 already, which indicates a fracture attached to a band which he is pulling on in this drawing. We found another very mysterious publication published in the 70s from Jack Houston. He published on a middle third lateral capsule ligament, no further description, no anatomical drawing or photos or whatever. And then Werner Müller in the 80s, he described a theoretical model for an anterolateral structure controlling rotation. This is a theoretical model. This is not anatomy. And then finally, a fourth publication we could find, which is a very mysterious thing. This is a publication calling an anterior oblique band. And so these four publications were the ones we had in our hands to go to the lab and start dissecting the human knee. This was the first knee I've ever dissected in search of some of these ligaments from the previous slide, and I'm sure if this knee wouldn't be so clear anatomically, showing an ALL running obliquely above the LCL, probably the rest of the story would have been completely different. But this was a very puzzling finding for us, and this gave rise, of course, to a lot of other dissections, more than 40, in which we identified this anterolateral ligament in every except one case. And as you can see on the video, the ligament is really running and is becoming tense during internal rotation, as you can see, and it runs from the lateral epicondyle in the direction of the anterolateral tibia. So we published this in Journal of Anatomy, as you probably know, and later on we published similar series together with Dr. Laprade in the American Journal of Sports Medicine. So once again, the femoral origin of this ligament is posterior and proximal to the lateral epicondyle, while the tibial insertion is in between Curtis tubercle and the fibular head. So we also describe this connection with the lateral meniscus. At some point, there was a debate whether the ligament exists or not, and then Camilo came up with this beautiful systematic review, putting together all the literature, what was available at that time, more than 50 publications on ALL anatomy, and only 2 publications could not find this ligament. So I think this is overwhelming evidence, of course, for the existence of it. It's also not just capsule, it's an anatomical structure, but it also looks and acts like a ligament. This is what we have been proving in the lab. So we took a piece of anterolateral knee capsule and we took the ligament and we test this in the loading frame. And as you can see, the ALL behaves completely different than just capsule. It's stronger and it snaps and has properties of a ligament instead of capsule. Also ultrastructurally, demonstrated by Camilo's group and also in Roma, we know now that this ligament under the microscope has an organized anatomy, which is collagen fibers like ligaments and not loose connective tissue, as you can see in the far right as capsule. So also under the microscope, it has the anatomy of a ligament. So as a take-home message, I think you just need to remember that the ALL is a distinct ligament. It runs from the femur to the tibia at the anterolateral aspect of the knee, femorally, posterior and proximal to the lateral epicondyle, and at the tibia in between Gerdy's and the fibular head. Thanks.